And just, oh, that's a good sign, right?
They have started the recording. Caitlin, just let us know when you're ready.
Yep, it's loading. Give me 1 second.
So while that's loading, just to let the board members know, so Mike Lane is not able to join us today.
Oh, wait, sorry. I have to restart it. It just auto went to the public health. Sorry, give me 1 second. Okay, good to go.
Thank you.
All set?
Yes.
Great. All right. Well, good morning, everyone. Happy September. So thank you for joining us. Thanks for the public community members who joined us as well. So we'll begin our board meeting. Also, Dr. Jayraj can't join us either, right, Christina?
My understanding was that he was planning to join.
Okay. Okay. So I'd like to ask first for the approval of the minutes.
So moved.
Thank you. Second. Steve raised his hand. I'm going to take that as a second.
Second, yeah.
Thank you. Any comments or changes? All in favor? Aye.
Aye.
Thank you. Okay, so we're going to jump right in. We have quite an agenda, and everything was posted on the website. All the materials, including the agenda, the minutes, and the OPH program summary report. So we'll start with Christina this morning, giving the health administrator's report.
Good morning, everyone. Thank you for joining us this morning. The administrator's report is an opportunity for me to share with you all key personnel changes. And actually, if we can go to the next slide, it'll give a little bit of an outline of what I'll be sharing this morning. There we go. Key personnel changes, updates about new funding that supports our work, contracts or grants that we have issued in our county to support local capacity. And it also gives me a chance for me to update you all on trends, emerging issues, policy changes that we're seeing at the state and national level and how that impacts us locally. You'll hear from Dr. Lorraine in a little while about fall respiratory season. That is one of those emerging issues or challenges or opportunities that we're seeing at the national, state, and local level for us to be communicative about what we're observing and what we're offering and how we're supporting our local community. I do want to take a little bit of a moment to share or talk through some of the things that we're noticing at the federal level, particularly with the CDC, because we've received some questions about how what's happening at the federal level affects us locally. So as you know, there's been quite a bit of upheaval at the CDC in the past few weeks, and in our nation, this is the sort of central aspect of our nation's public health infrastructure. I'm not sure if all of you are aware, but there was a shooting at the CDC in August in which an individual fired hundreds of bullets at the buildings on the CDC campus from a CVS across the street. While no one on the campus was injured, a responding officer lost his life, and the gunman also died as a result of self-inflicted wounds. 2 weeks ago, we saw the firing of Susan Menares, the CDC director, followed by the resignation of several high-level leaders who have dedicated their careers to protecting the health and well-being of our country. In addition, we're seeing quite a bit of confusion about access to COVID vaccinations and concerns about access to and recommendations for other vaccinations that keep our nation healthy and well. And I'll tell you that, it has an impact on us locally, particularly insofar as it affects morale. The work that we do continues every single day, in spite of what is happening at the federal level, in spite of the staffing changes, the staffing losses at the CDC. And while we do heavily rely on the CDC for guidance, for technical expertise, the work that we do continues here every day in very important ways. It makes the work that we do locally even more, I think, important. And it's critical that we maintain our local public health infrastructure, our state public health infrastructure, particularly during this time. We hear stories every single day from our staff, from our residents, about the impact of our work locally. Just yesterday, I heard a story from our staff about two of our staff, Meg and Alyssa from our communicable disease team, who really worked to create a strong and trusting relationship with a family that they were interacting with as a result of a case investigation. They were able to create that trusting relationship and really, from what we heard, change a family's sort of understanding of what local public health does and what our public health infrastructure does. This happens, at a time where there are questions and there's confusion and there's, mistrust in a lot of ways about public health. And so the work that happens locally really is the bedrock of that trust relationship and how folks perceive and understand what public health does. And so I really want to say thank you to our staff, our team here, to our residents who contact us all the time with stories about how they've found support and resource and help through local public health infrastructure. And also say thank you to our state and our federal colleagues who are continuing to persevere and work through the many challenges that we're facing every single day. I'll take a beat there. Are there any questions about what's happening federally? Okay, hearing none.
Yeah, Christina, I don't have any questions, but I do think, as a healthcare leader, for me, it is difficult, and we're getting questions, about the COVID vaccine and access, and there's just things happening every single day. So it's very important that we, try to pay attention and try to be available to answer questions and make sure that, again, it's a fluid time, and I have infection prevention physicians saying, it's difficult when people think they can't get a vaccine, or that they fall into the category and they need a physician prescription, but then they go to CVS and they don't need their prescription. And, so again, I think it's a little unsettling for people, and to the degree that we can put things on the website to inform people, or if we can tell people where they could get what the necessary vaccines they want within Montgomery County, I think that would be helpful. I don't know if we have that available now, but maybe that's something we could think about doing.
Absolutely, and I appreciate that, and agree, right? The information that we're sharing, the information that we can share, I think, it's important for us to have trusted, evidence-based sources of information. We will be sharing information actually about our fall community vaccine clinics within the next few weeks, and opening up appointments for those. So I appreciate your call out, particularly around the COVID vaccines and access, and making sure that all of our residents have access when they need it. We will actually be adding information about that to our website within the next week or two. So thank you for calling that.
Thanks.
Yeah. Also locally, I would say that we are, while we're witnessing these, concerning developments at the federal level, public health work and infrastructure, again, becomes all the more important at our local level. Here we are building our capacity internally at the Office of Public Health, and we're also building capacity in our community. Again, this is an opportunity for me to share a little bit about key personnel changes, new contracts and awards, funding updates. We did receive our year 3 notice of award from the CDC for our overdose data to action project. We are in year 3 of this 5-year program. We don't quite know yet about year 4 funding, and we'll know a little bit more about that after the FY26 federal budget is passed. But we have received full funding for our year 3 work. And this is work that allows us to really take a targeted, data-driven approach to preventing overdoses in Montgomery County. This represents a partnership between the Office of Public Health and the Office of Drug and Alcohol, and a really an opportunity for us to really invest in on-the-ground resources that help connect people with treatment, with other care supports, connect people with resources like Narcan and training on naloxone administration, and again, use that data-driven approach to really focus our investments in places where they're needed most. In addition to that, last week, our commissioners approved 3 new contracts from the Office of Public Health to community-based organizations to develop and expand community health worker programs. The overarching goals of this work are really to increase access to and utilization of healthcare by reducing barriers to care and increasing knowledge about health and health literacy. This RFP was actually issued earlier this year in direct response to what we learned through our community health assessment and some of the needs that we observed and noticed in that report. We expect that the organizations that were approved for funding will address some of the specific needs and barriers that came up in that report. We are issuing those notifications to those awardees this week, and so we'll be excited to share a little bit more about the work that they're doing in the meetings ahead. In addition, the Board of Commissioners last week approved 13 grants totaling $610,000 to community-based organizations serving Montgomery County. This grant program was initially conceived through our prior commissioners during the ARPA grant application process. At that time, several applications addressing food system gaps and needs were received, and in response, we formed a food policy council and allocated $600,000 for food system projects identified by that council. So since that time, we've hired a food policy program coordinator, Sam Applefield, who joined us, I believe, at the last meeting. And he's led the development and implementation of that food policy council, as well as a grant process to award the funds that I just mentioned. Earlier this year, the Food Policy Council leadership team designed and then launched an application process. There were more than 60 applications requesting more than $3 million in grants. And it was a very difficult but rigorous review process, difficult choices, but 13 applications were then recommended for funding. And we were fortunate to be able to announce that in partnership with our commissioners last Friday at the Upper Marion Food Cupboard. The projects are diverse in their scale and their geography, and they include increased capacity at food pantries, infrastructure grants at food pantries so that they can offer more perishable foods, fresh foods, development of new commercial kitchens, and infrastructure projects at farms that enable them to extend their growing season. Last, in terms of key personnel, we've added a workforce development manager. She is responsible, Emily Kramer, she's responsible for leading the implementation and of recommendations that came out of our workforce assessment. So this is our internal capacity building. She'll be prioritizing development of an OPH-wide onboarding process for all of our new staff, development and implementation of training and professional development for our team to build skills and professional advancement within public health, and development of an internship program so that we can continue to welcome new folks into the public health pipeline. Those are my updates, quite lengthy for today, but thank you very much for your time.
Any questions or comments?
Well, it's a lot. Thank you.
Okay, Christina, I think that we're good.
Great.
So we're going to move on to Denise, the OPH 2026 budget review.
Good morning, everyone.
Good morning.
Here's a snapshot of our overall budget for 2026. And as you can see, our proposed budget reflects an increase in expenses to 19.4 million and a decrease in revenue. This results in an increase in county contribution. Next slide. So our total revenue is projected to decrease by 3.6%. This is our fee-based revenue is increasing, driven by our annual 2% increase, our fee increases, and then our grant revenue is anticipated to decline because of loss of some funding. Our total expenses are projected to rise less than 2%. Our wages remain to be the largest expense category. Our controllable expenses show a slight decrease, and our non-controllable remain relatively stable. Next slide. This slide outlines our funding sources, with the county contribution being the largest at 32.4%, grant revenue following, alongside our Act 315 funding. Additional funding comes from our fees and our Act 12 source. Next slide. Okay, here's a list of our complete categorical contracts. This is based on all of our contract terms. It's not based on for 2026 calendar year. I just wanted to give everybody a picture of how much money contractually comes in and the terms and how that is funded, whether it's state and or federal dollars. So I also wanted to take a minute to look at our budget landscape over the past couple years, showing the key shifts over time. So as you can see here, both expenses and revenue experienced significant increases in 2021 and 2022 due to the pandemic. Revenue peaked in 2022, primarily again driven by COVID-19 related funding. Expenses surged in 2021, again, as a result of the pandemic. And now we're seeing a gradual reduction to baseline to where public health operational funding is more stable now. Next slide. Okay, so bottom line here is our impact is our revenue is decreasing. Expenses remain relatively stable, but ultimately this increases county contribution.
Does anyone have any questions about changes to, or the trends, I guess, in our budget, both revenue and expenses over the past few years?
No, I want to go into it a little more depth, but no, thank you.
And sort of coming back to, those changes at the federal level, a lot of folks have asked, how the, how federal funding is changing for us here locally. And you'll see there that, quite a substantial amount of our funding does come from the federal level, either directly through projects like the Overdose Data to Action Project. We also receive funding directly from the U.S. Department of Housing and Urban Development. But we also receive funding that goes from the CDC to the state to the local level. In fact, quite a substantial proportion of CDC's funding goes out to states or to local levels or both. So, what we're noticing right now is that, we have confirmed reductions in funding for things like immunizations. We have projected for next year reductions in funding for things like public health emergency preparedness. But we haven't yet noticed changes in other grant funding from the CDC or from the federal level, like the work that we do with housing, some of the work that we do with lead abatement, for example, maternal and child health work. We're watching very closely the FY26 budget process to see what changes might occur for future budget periods. But at this time, we haven't quite noticed those changes. If you have questions about specifics, what comes from the federal level, what comes from the state level, we're happy to field those, or we can, let you think on them a little bit more and take those at another time.
Okay. I think we'll move on, Christina. So we're going to move on to Dr. Lorraine and his report on Headed for a Fall, update on respiratory illnesses and immunizations.
Thank you, Barbara, and good morning to everyone. And thank you to the members of the public who have joined us as well. I'm very happy to be able to share this information with you. So I'm going to be giving you an update on the respiratory illness season that we are about to enter into, and specifically looking at the vaccine preventable diseases and where we are with immunizations for those. The subtitle of the presentation is Headed for a Fall, and it's interesting to me how one single letter can kind of change meaning. And I will elucidate on that a little bit more as I go along. Next slide, please. So putting it all together, what I'll be talking about, the outlook for this year is that we're going to expect to see something similar to last year. So the peak hospitalizations for flu, RSV, and COVID are likely to be pretty much the same as it was last year. COVID is always a little bit of a wild card, and if we see a variant emerge that escapes immune control, the cases could go up. Obviously, there's no specific way of predicting this, so we just have to see what happens. COVID is constantly mutating. And other viruses do that as well, but COVID does it very, very frequently. The current variant that we're seeing actually is not quite the same one that's in the vaccine that's been approved for this year, but it is similar enough that we do expect there to be fairly robust protection. It's of note that last year, the influenza season was significantly larger than the prior year. We don't have final numbers yet for the season because actually the official end of the season for all respiratory illnesses is the end of September. So we're actually still accumulating data for 2025. The part that is referred to in my subtitle, Headed for a Fall, is this one. The vaccine uptake for flu and COVID is still suboptimal. It has been and likely will continue to be so. Flu in particular, we've had campaigns for many, many years describing the importance of annual flu vaccination, yet the uptake seems to remain fairly consistently slightly below 50%. For the last few years, we've also had RSV vaccine available, and millions of doses have been distributed. And it's very likely that we're starting to see some effect of that RSV vaccine at this point. And we'll take a look at some of those numbers as we go along. Next, please. So here's where we stand at the moment. Not surprisingly, it's a pretty good map across the United States. There's very low or low incidence of respiratory illness pretty much across the country, with the exception of Louisiana. There may be some things going on in New Orleans that lead to the spread of communicable diseases, but I don't know that that's necessarily different than usual. But for the most part, we're in a good state right now. In most cases, we are at a very low level in early September. A couple years back, we did have a very early peak of respiratory illnesses, if you recall the triple-demic that we referred to a few years back. Next, please. So here's what we were looking at for the last 2 years in terms of influenza burden. Now, let me put a caveat on all of these slides where I'm going to show these numbers. These are estimates, particularly when it gets down to the state and the county level. Some of the data is not entirely reported or is aggregated. So a lot of these are estimates. They do have fairly good validity. For ones where I felt that there was a little bit of lack of reliability, I have not included them. But the ones that I will be showing you, we can pretty much rely on just keeping in the back of our mind that they are estimates. Total flu illnesses for last year in the United States, roughly 56 million as compared to 40 million the year before. And both the state and the county numbers reflect that as well. The number of hospitalizations remains significant, and it's estimated that we could decrease these numbers significantly, also deaths, by a more robust vaccine acceptance. So we continue to strongly recommend vaccination. Next, please. So RSV, I've only limited this to the symptomatic illnesses because I felt that the data for hospitalizations and deaths was not entirely reliable. There's significant numbers. If you'll note, the preliminary numbers, at least for the country, seem to be a bit low for this year, but we don't have final reporting yet, and the year has yet to finish out. And I really expect within the next year or two, we'll be seeing the effect of the RSV vaccines and the monoclonal antibodies that are given to children. Next, please. And this is a good graphical representation of where we see things over the past few years. I really only looked a lot at the last 2 to 3 years because prior to that, the pandemic had really, really altered these numbers significantly. But you're starting to see pretty much the resumption of the curves that we saw prior to the pandemic. Note that very, very early spike in flu and RSV from a couple years back. That was the triple-demic that I referred to before, and the fairly large spike for influenza for last year. Right now, we are expecting that we could see that similar spike in influenza. Next, please. And looking at the COVID-19 burden over the last couple of years, looking at both, looking at the country, the state, and the county, the numbers stay relatively consistent. And if you look at the ratio of hospitalizations and deaths, it's higher than it was for influenza, which is not surprising. People who are hospitalized for COVID tend to be fairly severely affected, and there's a fairly higher rate of mortality with that. But the numbers that we see are significant. Even within Montgomery County, we saw over 100 deaths due to COVID for the current year. Next, please. Moving on to immunization. So here's a metric for the country in terms of total doses that were given for influenza, for COVID, and for RSV. As you can see, the amounts are significant. The total for the country, 147 million, given that the total population is somewhere, I believe, about 380 million, something. I'm fairly close to that. So it's a little bit less than 50%, as I was talking about before. COVID vaccine, we see those doses, 30 million. That's a significant amount, but at this point, the uptake is relatively low. And RSV, the last couple of years are really actually aggregated here because that's when it really first became available. So that's referring to pretty much the total number of doses that have been given since the approval in 2023. Next, please. Here we're looking at the vaccines that were administered directly by the Montgomery County Office of Public Health. On the top, you'll see our total, and this is between both our community clinics and our ongoing office clinics in Pottstown and in Norristown. We were able to break it down by age group for the total, and in our community sites, we have pharmacy partners that allow us to give vaccine to insured individuals as well as uninsured, which is our mandate. So we have that breakdown there. And you can see that in our community sites, we're actually immunizing roughly half and half, insured and uninsured. And the participation of our community partners, which allows us to use their vaccine and for that to be appropriately reimbursed by insurance, is very, very important, both in terms of the amount of vaccines that we can administer and for extending our operating ability to be able to vaccinate as many uninsured folks as possible. Next, please. Starting off with the easy recommendation, influenza vaccine really hasn't changed very much. So the current guidance that we're receiving is everyone 6 months and older is recommended to get an influenza vaccine for this season. Special cases, older adults are supposed to get a higher dose or a recombinant/adjuvanted influenza vaccine. And the reason it's preferred for this group is because we want to make sure they have a good immune response. People 65 and older do tend to have a somewhat attenuated immune response to vaccination. Children 6 months to 8 years, if they haven't received a flu vaccine at all, it is recommended they get 2 doses 4 weeks apart. If they have received a flu vaccine in the past, then they would just simply get a regular influenza vaccine. For pregnant women, the official recommendation is a single dose thimerosal-free flu vaccine. I'm going to digress for just a second and talk about thimerosal. Thimerosal is a mercury-based preservative. And it had been used a lot in vaccines up until about 1999, 2000, where it was recommended to be removed over concerns about mercury as a potential neurotoxin, uh, a, um, a problem for the central nervous system. The thing about the mercury that's in thimerosal, and forgive me for doing a little bit of organic chemistry, but I'm going to keep it quite as straightforward as possible. So the mercury that is in thimerosal is something called ethyl mercury. It's combined with an ethyl molecule. The mercury that, for example, is in tuna that we consume is methyl mercury, a methyl molecule as opposed to an ethyl molecule, and there's a 1 carbon difference on this. The studies have shown fairly clearly that the ethyl mercury that comes from thimerosal is very quickly cleared from the body and does not accumulate. The methyl mercury stays in the body for a while and potentially can accumulate. We also have definitive studies which show very clearly that thimerosal, when used as a preservative vaccine, actually does not accumulate, does not cause mercury toxicity, really doesn't cause a problem at all. Yet in 1999 and 2000, out of an abundance of caution, the recommendation was made by the FDA to remove thimerosal from all childhood vaccines, which was done. The only vaccine actually that still continued to have the thimerosal in it was one of the multi-dose flu vaccines. Recently, the current Secretary of HHS in Washington raised the issue, and at his behest, the recommendation was to remove thimerosal from all vaccines. It really is kind of a moot point because we as a county weren't using it. Most organizations weren't using it, and it really wasn't much available, and it really doesn't cause a problem. But yet it's still being raised as a potential issue with vaccines. It is my personal belief that that's being used to raise a specter of questions of safety regarding vaccine that is inappropriate and inaccurate. Okay, off the soapbox. Immunocompromised individuals, so people who are significantly immunocompromised by the use of immunosuppressant medications, basically follow the same guideline as adults 65 and older to get the higher dose. Next, please. All right, RSV vaccine. So the guidelines for the RSV vaccine did change a little bit recently. So it's really important for older adults to get this RSV vaccine. And right now the recommendation is all adults 75 and older. It is approved for 60 and older. So the current recommendation is for adults who are 60 to 74 to get the RSV vaccine if they are at increased risk. So if they have additional conditions, heart disease, lung disease, diabetes, things like that, this is usually done after consultation with their individual provider. And right now, again, it is a single dose vaccine. It is quite possible in the future that a booster may be recommended, as the immunity does seem to wane after 2 or 3 years, but right now it is a single dose. So adults who have previously received it should not get a second dose. The chronic conditions, the higher risk, are elucidated in the third bullet point there, as I already discussed. Pregnant women are also recommended to get one of the specific RSV vaccines during their pregnancy. And the reason for this is not only for the pregnant woman to be protected, but also the child up to age 6 months. Because we don't immunize children at all for RSV, but there is what's called a monoclonal antibody available for them. But that's not given under the age of 6 months. So the protection that an infant up to 6 months would have would be the passive immunity, the antibodies passing through from the mother from this vaccination. So it is strongly recommended. And as you see in the final bullet point, the monoclonal antibody that is available, and a new one was relatively recently approved, is recommended to be given to all infants who had not received that, all young infants who had not received that passive immunity from the mother, or if they're at high risk for RSV illness. And we are seeing the effect of this on the decreased number of children being admitted to hospitals with severe RSV infection. Next, please. All right, so we had 2 of the 3 vaccine preventable diseases with relatively straightforward information as to who is recommended to get it. And as has been alluded to before, right now in terms of COVID vaccine, there's a lot of confusion out there. The big step that happened was at the end of August, the FDA issued an approval for the updated COVID vaccine for this year. And there's specifically 4 vaccines. So Moderna and Pfizer have the mRNA vaccine. Novavax has a different, more traditional type of vaccine. As an interesting sidelight, Moderna now has a second COVID vaccine. The first one was called SpikeVax, and the next one is now mNEX Spike. It actually targets more specific parts of the spike protein, seems to produce a somewhat more robust response, maybe a little bit less side effects as well. And I'll get into the recommendation for that later on. Now, the big change here was that the emergency use authorization for children for the Pfizer vaccine was removed. The specific groups for whom the COVID vaccine is now approved, again, are 65 and older and younger than 65 with a chronic condition that puts them at higher risk for severe COVID disease. For everyone else, there is no longer an approved COVID vaccine. That's the big difference. The ACIP, the Advisory Committee on Immunization Practices, which is an arm of the CDC, was scheduled initially to give its recommendation in June, which they did not do. And they have a meeting scheduled coming up on September 18th and 19th, where if they do meet, it is likely they will issue their recommendations. This is kind of a little bit of a backwards process. In the past, what's happened is the FDA issues an approval for a vaccine. Then the ACIP kind of hones in a little bit and gives specific recommendations on who should get the vaccine. This time, the FDA restricted access to the vaccine by approving it only for certain high-risk groups. I will tell you that to a certain extent, that's not a bad thing. I have noted, and many others in the medical field have noted for the past couple of years, that we really do have a little bit, we really do need to have a little bit more of a targeted approach in terms of our recommendation for COVID vaccine and look more at the risk versus benefit that we use in everything that we do in medicine. But it has the effect now of restricting access for those who are not at high risk yet still want to get the vaccine and have made that their individual decision on that risk versus benefit. So, especially given our mechanism of providing immunization, it has created a lot of confusion. Next, please. I really went through this already. So the Moderna vaccine and the Pfizer vaccine are recommended for people at high risk. The Moderna vaccine is still approved for children. The Novavax has the approval for individuals 12 and older at high risk as well. Next, please. So I talked about that, risk factor for a higher risk of severe illness of COVID. This slide is taken from a presentation by the chairman of the ACIP back in February. And she specifically listed the conditions that are conclusively proven by the data to put people at higher risk of severe illness of COVID. There's a lot of things there that we think are fairly obvious. I would draw your attention in the final column to 3 particular things: obesity, physical inactivity, pregnancy, and recent pregnancy. So these are things that the CDC considers to be conclusively conclusively proved to cause higher risk of severe illness of COVID-19. Next, please. So if we apply that to the general population, if we look at only just one of those risk factors, how many people does that affect? Well, the answer is a lot. If you look across the adult population, roughly 3/4, 74%, have at least one of those conditions. If you pull out people 65 and older for whom it's specifically recommended, you still have a relatively high percentage. The lowest that it really goes is about 2/3, 65% of adults have one of those conditions. So one of the things going forward that people really need to look at very closely is to look at that list of high-risk conditions and try and self-identify if they have one of those things, which would make them eligible under the current FDA approval to get a COVID vaccine. Next, please. Well, the FDA approvals were somewhat restrictive, and organizations of physicians and medical organizations that have looked at this issue closely have come out with their own recommendations, which now differ a little bit from the CDC. Most prominent among them is the American Academy of Pediatrics. The thing that the American Academy of Pediatrics looked at, and based on clear scientific data, they noted that of the hospitalizations of children for COVID, the majority of them are children under the age of 2. And therefore, they felt that given the risk-benefit analysis for that age group, all children under the age of 2 should receive a COVID vaccine. For those 2 to 18 years, they said that, somewhat in agreement with the CDC recommendation, if the children were at high risk, they should receive a COVID vaccine. However, they expanded that high risk to a certain extent. That's also including if they are resident of a long-term care facility or a congregate setting, if they've never been vaccinated at all, or if they have household contacts who are at high risk for severe COVID disease. Next, please. The American College of Obstetrics and Gynecology still makes a strong recommendation that pregnant women receive COVID vaccine.
Dr. Lorraine, you're froze, but I don't know if it's just my computer or not.
I think it's Dr. Lorraine's feed coming in.
Okay.
Give him a moment. I sent him a note just to let him know because he may not be aware. And it looks like he's disconnected and hopefully is reconnecting in a moment. Yep.
Okay, I'm back in.
There he
you
is.
are.
Are you able
Now
to see
we
me?
hear you.
Okay.
Yep, hear you.
Sorry about that. I don't know. I just dropped completely for some reason. The gremlins are attacking me. So going over the American College of Obstetrics and Gynecology guidelines, they do strongly recommend that pregnant women still get a COVID vaccine. The CDC is inconsistent in its own recommendation right now. With great fanfare, Secretary Kennedy announced the removal of that recommendation for pregnant women back in May. They did take it off of their website. However, if you go on their website even now and look at the high risk factors for severe COVID illness, pregnancy is still on there. So the ACOG still makes the strong recommendation that pregnant women should receive COVID vaccine. Next, please. What we saw as a result of this was there's a lot of confusion, mostly with the pharmacies who were distributing COVID vaccine. And because they figured so many people either would be confused about whether they fit the criteria for the FDA approval or they don't fit the criteria and it would become what's called an off-label use. In Pennsylvania, they made the announcement they were going to withdraw completely from administering COVID vaccine. And that caused a lot of uproar and confusion. Governor Shapiro, about 2 weeks ago, issued a statement, which you can see there, and he called upon the State Board of Pharmacy to meet in special session and try to clarify this and make sure that we do have access to COVID vaccines in the Commonwealth of Pennsylvania. So the board took action about a week ago, and we'll see specifically on the next slide what their statement said, but it did now allow the pharmacies to resume administering COVID vaccines without requiring a prescription from a physician. And most specifically, it now allows guidance from professional medical associations. Next slide, please. Here's their press release, and the big difference is that prior, the guidelines for pharmacies were that they could administer vaccines according to the ACIP recommendation only. And what they've done now is they've added other valid sources of authority, such as the American Academy of Pediatrics, the American Academy of Family Physicians, American College of Obstetrics and Gynecology, and the Food and Drug Administration. So that now gave enough freedom for them to come back at least into the market and say that they will be administering vaccines. There still is a little bit of work to be done on figuring out exactly the logistics of this. And again, what we're going to be doing in regards to those individuals who do not fit any of those criteria. Next slide, please. So having said that, here is a proposal which has not yet been approved by our solicitors and our commissioners in terms of what we will be doing as far as the Montgomery County Office of Public Health in our community clinics. It's a combination of the FDA approval, the AAP recommendations, and the ACOG recommendations. And it also does follow along with the latest State Board of Pharmacy guidance. Next, please. Excuse me. So the proposed eligibility for COVID vaccine, ages 65 and older, and those at high risk, are first 2 bullet points. The next 3 bullet points are the additions. So all children up to the age of 2 who do not have a specific contraindication to the vaccine, the children who are residents of long-term care facilities or other congregate settings, have never been vaccinated, or have household contacts who are at high risk for severe COVID. So those are the AAP recommendations. All pregnant and lactating women, which are the ACOG recommendations. Next, please. The way that we're going to be administering this is that anyone who does not fit the FDA approved guidelines, so that would be anyone younger than age 65, essentially, we will ask them to review a list of those approved indications for high risk of COVID disease and attest that they have at least one of those conditions. We will not be asking what that condition is. We will not be asking for documentation or a physician's note. We just ask them to attest that they have one of those conditions. This is very similar to procedure that we used earlier on in the pandemic when the boosters first came out. Also, when the vaccine first came out and it was limited to certain groups, we asked for self-attestation at that time. So it's a very similar process. Right now, we're still determining if we will be able to administer COVID vaccine to healthy individuals under age 65 who don't have one of those at-risk conditions. We don't have a final answer on that yet. There will be absolutely individuals who do not meet one of those high-risk criteria who still desire to get a COVID vaccine. And we are cognizant of our responsibility as a public health agency to try to assist them with that. We're still working on that, and we're looking at the regulations, the legalities, and our other obligations in terms of language with contracts with the federal government. So more to come on that. Next, please. And with that, I've hopefully taken a situation which is clear as mud and maybe stirred it up a little bit, but I'll be happy to take any questions if I can answer them. The one thing I can assure you is that we are actively working on this. And as new developments come along, we are incorporating that into our procedure. We're discussing it. We're doing what we can do within the boundaries of regulations, within the boundaries of the legal responsibilities, and within the boundaries of our responsibility as a public health agency. We are cognizant of all of these things, and we are trying to put it all together in the best way to serve the public that we can. Thanks.
Any questions for Dr. Lorraine? That was a lot of things that you covered.
Sorry, it took longer than I expected.
No, it's okay. It's okay. Questions?
I'm exhausted.
And that's how I feel.
It's not a question, but Rich, really good job. Excellent, excellent presentation.
It was
Thank you.
really good. It really is good. Okay. So one thing, do we anticipate, and maybe this is a repeat of my earlier question, but will we, as we get more clarity potentially from the CDC, will we update the website so that people know whether they fall into the category, et cetera?
Oh, absolutely. Absolutely. We want to try and make it as clear as possible on
Yeah.
the website, which will really facilitate
Okay.
scheduling at our clinics or going to one of the pharmacies, wherever people choose to get their immunizations. But we
Great.
will strive for clarity.
Yeah. And the newest COVID booster is available. Like it's the updated version, right? So that's actually available today.
Yes, it has been shipped. Not everyone has received it yet, but I know that there are certain pharmacies that are administering it. Once this new one is available, the old ones are not used at all anymore. This is an updated vaccine, more specific to current variants.
That's great. Okay, thank you. All right. All right, thank you. I think we're going to move on to the Office of Public Health Priorities with Jay Kim.
Yes, good morning. Next, each division director will provide a mid-year update on their 2025 division priorities that will cover activities from Q1 and 2. Okay, and we'll start with clinical services. Ruth Cole.
Okay, good morning, everybody. So for the first priority is involving our electronic medical record. We are still pursuing a switching. Currently, we use Patagonia as our EMR. We are considering another EMR, and we are planning a site visit to see a review of the Epic system. So stay tuned for that. We're excited at the possibilities of transitioning, but as you are well aware, it's a long process. Secondly, we are continuing to work with the communicable disease division for assisting pregnant women who are diagnosed with syphilis. At times, private providers do not have the treatment that they're needed. We work with the providers to provide them with the treatment for pregnant women. And lastly, I am very excited to say that in terms of our staffing capacity, we are on the increase. We are in the process currently of hiring 3 part-time / pool nurse positions that will start in October. They're on track for that. Excitedly, they are 3 people that worked full-time for us in the past, so they're public health nurses in their training, and 2 of them are bilingual, English, Spanish. So we're very excited to add them to our complement. That will mean that we have just about full capacity for our part-time slots, with 6 out of 7 filled. And in terms of our full-time positions, we have 14 out of our 18 public health nurse positions filled, which is a 78% capacity rate. So we feel like we are making good headway at this point.
Ruth, that sounds really good compared to what I recall previously. So that's very exciting to hear that you've been able to fill your positions. That's great.
Yeah, and we have a great team.
Okay, thank you, Ruth. Next slide, please. We'll go to communicable disease. Michelle Masters.
Good morning, everyone. So we, for our 3 priorities, first one we've talked about several times is developing a training and resource educational webinar for our acute care and long-term care facilities around healthcare associated infections, containment strategies, and infection prevention control. So what we've been working on is making sure that our staff here have the training to be able to provide that educational webinar, as well as engagement with our acute care and long-term care facilities that we work with on a frequent basis to assess what they need and what they're looking for with educational webinars. So we want their input so that they are able to engage with those sessions. So we did that research in Q1 and Q2. Second, which links back to what Ruth had talked about with the interdepartmental collaboration, is a partnership with Clinical and the Maternal and Child Health Program to support pregnant women that are diagnosed with syphilis, to make sure that they are linked to care, they receive treatment, and try to reduce congenital syphilis. So again, we are in the implementation phase. We've done some research. We are training staff here. We did have new staff this year that had to complete CDC required trainings. And then working forward with Clinical to make sure we have a referral process for treatment. And then lastly, trying to utilize technology in these times, we wanted to develop, pilot, and evaluate an online salmonella case investigation questionnaire form. So typically we do case investigations over the phone with residents that are diagnosed with salmonella. That is very intensive, and it takes around 45 minutes plus for our residents to go through that. That is a long time for people to have throughout their workday. So we started to develop a salmonella questionnaire. So we've done research for questionnaires that are out there already. We've also engaged PADOH and other health departments to see how they've been utilizing online surveys to see how we can be successful. So really overview in Q1 and Q2 is we've really tried to spend time to make sure staff are trained, and we've done research to see what has worked and not worked in other entities.
Michelle, that's great. Would this survey be texted to people?
Yeah, so the hope is that it could be email, text, or we can send it to healthcare providers to integrate into their electronic medical record and their messaging, so to increase the ability of contacting our residents.
That's great. Thank you.
Mm-hmm.
Questions for Michelle? Okay, thank you.
Thank you, Michelle. Next, we'll go to Environmental Health Services with Pam Long.
Good morning. I will give you a quick update on our goals and priorities. So our first one is to research and identify a new inspection system. We've been working on this for a little bit of time. It does take time to find something that will work with our group and what we do. So we are in the progress right now of finding a vendor that will support the work that we do. So right now we use Digital Health Department, and Digital Health Department will no longer be supported as of December of 2026. So we have to find something soon, so we have time to develop it. So we are in the working on that right now. Our other goal was to reorganize our territories and staff structure. So in Montgomery County, it's over 60 municipalities. We had that broken up into like 3 different regions, but based on our staff and workload, we were able to now reorganize everything, and we are going to break down the county into 4 different regions. We are officially fully staffed. So we just are in the progress of training staff and trying to onboard everybody and maintain our staff levels. So hopefully we can do that. And it probably in the new year, they will be up and running and working in the new regions. So that's where we're at right now. Thank you.
Thank you, Pam. Any questions for Pam?
Pam. Next, we'll go to Health Equity and Epidemiology with Chantel Mason.
Good morning, everyone. Just some quick updates. So we are still working on streamlining our data collection process, including revising our data request form and SOPs. So in response to that, we have hired a data manager who will be supporting the streamlining of the data request process. That's Dr. David Walsh. and also participating in the HHS data governance meetings, just to make sure that anything OPH is doing around data collection aligns with HHS standards. Next, we have the health equity framework and the development of the health equity profile. So we did select 2 health equity frameworks to work with here. That's the Massachusetts Health Policy Commission and the CDC communicating about health policy concepts. So the report is slated to be released at the beginning of the year. Really quickly, the Massachusetts Health Policy Commission, it focuses on a few things. We wanted to make sure that whatever framework we selected, it could align with things that we were already doing. So it wasn't a heavy lift to get it done. It does focus on research and reporting on specific health indicators. Also partnering with stakeholders, including community-based organizations and other government entities. And then watchdogging, that includes just keeping an eye on those same health indicators so we can see, are things improving? Are the things we're putting in place actually working? And then lastly, convening again to bring that same group back to say, all right, did things work out? Do we need to pivot? It is a cyclical process, which is great because it has the checks and balances in place. And then there's also the CDC communicating about health policy concept, which is a great framework because instead of focusing on the disparities, it focuses on the inequities that causes the disparities. So the goal here is to not stigmatize groups that are experiencing the disparities. And so an example here would be looking at infant and maternal mortality. African-American women do not have the same rates as far as maybe experiencing higher rates of mortality as opposed to their Caucasian counterparts. So instead of just saying that African-American women are not experiencing the same rates, you would focus on what's the driver for causing that disparity. So it takes the blame away from looking at the group, and it more focuses on how we can create a healthy community. So again, we are slated to release the health equity profile beginning of 2026. And lastly, increasing public access to health data by creating data dashboards. Again, our data manager, Dr. David Walsh, who is part of the OPH team, will meet with the divisions to see what areas, what metrics that they have that they would like to have included in a data dashboard. The goal here is to increase transparency wherever it's appropriate to make sure that we are sharing data. And then he'll also be reporting out some opioid data to action grant data as well as appropriate. That's all I got.
Thank you, Chantel. Next, we'll go to health promotion. David Genova.
Thank you, Jay, and good morning, everybody. Our first priority is to address and prioritize the major health issues identified through the community health assessment. We created 2 objectives for Q1 and Q2. The first objective was to create awareness of the community health assessment key findings. We measured this through the number of views on our website, the number of social media interactions. We used 4 social media platforms, including Facebook, LinkedIn, Instagram, and X, which is formerly known as Twitter. 12 posts were shared from March to June. Facebook was the most consistently active platform, with all posts showing measurable reach and interactions. Looking at the number of views on our website, in Q1, we had 3,773 views. In Q2, we had 2,973 views. The second objective was to share results and collective feedback of the CHA through community conversations. We measured this by the number of community conversations held, as well as the number of attendees. We facilitated 7 community conversations with 90 total people attending. Our second priority is to develop strategies to improve the overall health and well-being of residents through prevention and education. We are doing this in collaboration with the Division of Communicable Disease. We're focusing on infectious disease outreach and education. Health promotion and communicable have scheduled standing meetings. We created a cross-divisional channel on Microsoft Teams to improve communication. We added a shared calendar that lists upcoming health fairs and different community events. We're measuring this through, who's attending, materials distributed, number of people that we interact with. Communicable is also creating a general STD PowerPoint presentation geared towards high school children for our health educators to present on. Our third priority is to engage community health workers to provide health education, outreach, and navigation services to targeted populations in the county. We are at the very beginning stages of this priority as we recently solicited proposals from qualified vendors through an RFP process. We received proposals from 5 different organizations. We are funding 3 of them at $80,000 each. The contract term is from October 1st, 2025 through September 30th, 2026, with the possibility of a 1-year renewal. Thank you.
Any questions? Okay, thank you, David.
Thanks, David. Next, we'll go to emergency preparedness with Megan Young.
Morning, everybody. Couple highlights for the first half of this year for FEP. We continue to onboard our new public points of dispensing. So we've had a points of dispensing program for distribution of vaccines and antibiotics in emergencies for quite a long time. After the COVID response, we quickly figured out we needed to change that delivery, improve that delivery based on what we learned from COVID. So the team has been doing a lot of really hard work this year to kind of figure out what the best place is to put these public points of dispensing and how to best administer that program. So they've made some great progress in the first 6 months of this year. Currently, we have 1 fully executed agreement with 2 more close to execution. I would say within the next 2 months, they should be fully executed. And we have meetings set up with at least 3 to 4 additional locations, and we're constantly looking to make sure we have adequate coverage. We also continue to improve all the response plans for the Office of Public Health. We have had several responses this year, which have created the generation of some new response plans around things like highly pathogenic avian influenza. Of course, we've improved our measles response plan this year. And we're looking ahead to 2026. There's a lot of activities that we're potentially going to be asked to support. So we are ensuring that the response plans for emergencies are well shored up long before we get to 2026. We also have some response annexes that we hope to develop in the next year, including arboviruses, West Nile. Viral hemorrhagic fever is a constant threat, things like Ebola and Marburg virus, and then hepatitis A. So those are the goals for the rest of 2025. Our other really big goal this year is to just continue to grow the Medical Reserve Corps and recruit new volunteers. We have a great Medical Reserve Corps. It has grown a lot since COVID, especially. They have been a constant source of support around vaccine clinics, emergency responses. So we have a great core group of volunteers. But admittedly, that core group of volunteers is retired, older age, and they're not going to be here forever. So we are going to look to recruit some new talent, some additional specialties and things like that. So there's plans in place to create a marketing campaign and just continue to recruit new volunteers.
So Megan, it's Barbara. So what would be the appropriate number of volunteers that you would feel good about?
I don't have a set number in my mind. I think where we're at right now, I believe we have somewhere in the area of about 200 rostered volunteers.
Okay, that's great.
I would say about 45 to 50 that are consistently active. And that feels like I feel okay about that right now. I think we could do a lot of really good things with the numbers that we have. Our MRC volunteers have showed up consistently for the last 5 years. They staff all of our community vaccine clinics. They're staffing our health centers when we start to see surges for things like back to school vaccine. They are being asked to evaluate whether or not we could assist with things like homebound vaccines to increase some delivery of services throughout the county. So they get to do a lot and they do a really great job. But I also know that some of them will eventually actually want to retire for real. So, you know, we have to keep some folks in the pipeline. So, you know, we're going to probably be recruiting new retirees from the healthcare systems, as well as hopefully some college students and younger professionals.
I think that's great. Thank you for that. I'm not sure we had awareness that there were 200. So I think that's terrific. And we should be sure that we thank them for the support that they give us. But that's great. Thank you.
Yeah.
Any other questions for Megan? Okay.
Thank you. And lastly, water quality management with Kyle Schmidt.
Good morning, everyone. I apologize. For an hour now, my video has been uploading, so you're gonna have to look at my name right now. First I'll start with a plan for a Legionella training for my staff. Over time, I tended to do most of the work for when there's a Legionella outbreak, but I'd like to involve my staff more in these cases. So by year's end, I plan to present, and it's being planned, to present an updated and approved SOP for Legionella investigations. We've had some in the past, but we're updating it, and it's practically complete. I'd like to present on past experience that I've encountered since the early 2000s doing these Legionella investigations, which includes facility assessments, sampling, and then providing recommendations to the facility. And then I'd like to also provide professional training as well. I know that some of it can be found online. So all of that should be completed by year's end. So I'm going to have it done this fall. Next is succession planning. No worries, it's still several years away, but Jay and I discussed making sure that others know of my things that I kind of do myself, and I'd like to involve the staff more in especially private well or groundwater contamination cases that I tend to do the sampling and provide the recommendations. And also, when we have public water contamination cases, that I tend to be the main point person for water quality. So I'm going to start training and handing off those assignments to my staff, and there's other topics as well. And then finally, similar to Pam, I'm working on, or we all are working on securing the services of a new vendor for our electronic database. So we hopefully will have that in place and completed by the end of next year, which is the DHD sunsets at the end of next year. So we want to have that in place and ready to go before that occurs. So any questions?
Thank you, Kyle. And Jay, in interest of time, is there anything else we need to cover?
No, I think that's it.
Okay.
Other than the community health improvement plan, which is next. Yes.
Yes, which is next. So let's jump into that. And again, I think that, you know, we have about 15 minutes left. I'm not sure that's enough time, but let's jump in and let's see how far we get if Christina agrees.
I think we should proceed. I'm going to invite my colleague, Christy Goodwin. She's our Community Health Program Manager, to join me for this conversation. Christy has been leading our community health assessment process and has been working towards the development of our community health improvement plan. Christy, are you with us?
Yep.
Awesome. Is it okay if I turn it over to you?
Sure.
Awesome.
All right, so I'll go through this as quickly as I can. That way we have some time to talk and get your insight. So we are in the process of transferring from the CHA to the CHIP and setting our priorities, and then eventually determining our goals and their structure. So the top community concerns from the CHA were mental health, chronic disease, and environmental health. They're pretty similar across age groups and races. For mental health, it might have been higher in a younger age group, and chronic disease might have taken precedence with an older age group. But nonetheless, these were the three priorities that remained strong throughout that population that took the survey. You can go to the next slide. The next three slides just have some of the highlights of that data. So you can see that slightly more than half of the survey respondents rated their mental health as excellent or very good. We also noticed that perceived mental health improved steadily with age. 81% of non-binary respondents reported a need for mental health services in the past year. It was also higher for female respondents, as well as Black or African American. You can go to the next slide. For chronic disease, about 24% of survey respondents had met the recommended minimum 150 minutes per week of moderate to vigorous physical activity. Almost 89% were always or mostly able to access medical care when needed. And younger adults, so the 18 to 24, 25 to 34, and 35 to 44 age groups were the most likely to report difficulty accessing care. It was also higher in the Hispanic or Latino population as well, with about 46% reporting that they had a personal health care provider, compared to about 82% of non-Hispanic or Latino respondents. Go to the next one. For environmental health, it's a very wide definition. So the way we phrased it in the survey was food or water, neighborhood, roadway, safe and clean housing. So it incorporated the built environment along with feelings of safety, and also being able to have access to clean water and food. So 75% said it was easy or somewhat easy to find safe sidewalks and streets for biking and walking near their homes. 90% reported that safe outdoor spaces were easy or somewhat easy to find. And then we had 59% agree or strongly agree with the statement that they felt safe while driving on the road. Part of what I've been doing is taking a look at other community health assessments and CHIPs. So these are a few examples of CHIPs surrounding Montgomery County and examples of their priority areas. For us, we have mental health, chronic disease, and environmental health as our priorities. Delaware County also recently completed a CHA and began their CHIP earlier this year. Their priority areas are whole person health, substance use, and mental health. So they group that all into one. Also promote maternal, parental, and infant health, and then prevent chronic disease. I highlighted where like some mental health is in yellow, so you can see where that overlapped, some of the chronic disease being in green. For Philadelphia, their CHIP was in 2022. Their priorities were social determinants of violence, public health preparedness, and then access to care / community health linkages. Lancaster did one through their hospital system in 2023, and their priorities were safe and healthy environment, healthcare access and quality, and then again, mental health. You can do the next slide. So this is an example from Delaware County's CHIP. I just grabbed a few of the goals around mental health, just to give you an example of how they structured their goals. So where we would like your insight and guidance, and I believe that'll be coming up in the next slide, will be how broad or narrow to set the goals. So under mental health, one of their objectives is to decrease the proportion of Delaware County adults who experience poor mental health by 5%. And they also have improved mental health ratings among youth. Goal 2 for increased primary care access, their objective there focuses on adults ages 18 and older. So increasing the proportion who visit the doctor for a routine checkup. And then goal 4 is reduce obesity, and that's pretty broad, just decreasing the rate of obesity in Delaware County by 5%. You can go to the next slide. Okay, so this is where we can get into our discussion. So we'd like your feedback on the priority areas. So to find out what you're noticing within the categories of mental health, environmental health, and chronic disease. And then again on goal setting. So wide versus narrow, are your recommendations to go county-wide? So for Delaware County, they were focusing just on the rate of adult obesity in the county. Or it could be specific geography or specific population. So again, it could be youth, it could be done by race, it could be LGBTQ. So we'd like to hear what you have to say about, again, goal setting, and then just also your feedback on those priority areas.
So do people have suggestions or ideas? Does anybody who joined us in the community have anything that they'd like to raise at this point around these 3 priority areas? Or any other topic related to this? I mean, one thing, Christy, that I think about, so for mental health, like that's such a important category. Like I wonder, and I was glad you looked at what other health departments have seen, but you know, I wonder what does addressing or looking at mental health in Montgomery County, like what does that look like? What are the options for us? Like, is this part of, you know, community? When in any setting where we're interfacing with the community, do we touch on behavioral health, and do we touch on what's available within Montgomery County to support people who have a behavioral health crisis? Like I don't know all the potential things, but maybe there's a way where we make sure that resources are available and easily accessible, as far as like, where do you find support? What kind of mental health crisis are you having? Like if you're suicidal, like here's how you get immediate help 24/7. If you're concerned about someone who is a harm to the or danger to themselves or others, here's how you get help. Like, is that what it, like, I don't know what the, to me, it's a very big bucket. And I wonder if we can put resources and make them available to people, and even guide people of like, if you're having this situation, this is what you should do. You should go to the emergency department. You should call the crisis team. You should call the suicide prevention hotline.
Barbara?
Yes.
I think obviously with mental health, the earlier you go at it, the better. So that, like, obviously those of us who are in hospital-based, you know, we're seeing the tail end when they're in the emergency room and it's a suicide crisis, et cetera. Obviously, from my standpoint, I would think more of a broad-based approach of trying to, as you say, access mental health, but not in the end stages, but in the earlier stages. I don't know if there's a way to monitor, because you get into a lot of significant HIPAA issues. But if there was a way to see whether or not there was ongoing mental health work being done in the youth earlier on, I don't know if there's a way to construct that where you could say certain number of people have been having mental health appointments and we've seen an increase in those. But again, I'm not sure how much you can access those. But obviously in this one, prevention is so much better than being able to get somebody out of an ER when they're in acute suicidal crisis. I mean, again, that's the one that we feel the pain of, but it's probably better addressed on the earlier side rather than the later side. And then on my second thing, I was going to say, I kind of like in terms of chronic diseases to talk about the obesity thing, because things like even hypertension and even issues with regard to diabetes, there's not as much that you can sort of monitor and possibly what you can do. So the obesity one is a good one. I do know that on the state level, there's more and more activity being done focused on hypertension as a chronic condition within pregnancies and providing blood pressure monitors and that kind of stuff. And I don't know if we can dovetail into any of that kind of thing, but those would be when you're asking for the feedback, mental health would be my number one. Earlier, the better. But if you can't do earlier, even later is fine. And the broader on those would be possible. And then, as I said, I don't know nearly as much about environmental health. So going into chronic diseases, I do like the obesity choice. And if we are going to do something in the hypertensive realm, dovetailing with some of those people who are doing those programs to provide blood pressure cuffs to pregnant women, on the state level would be where I would go. And that's all I got.
Thank you, Marty. I agree with you. I think earlier, so maybe we partner with the schools around mental health for children and young adults, and also identify places for acute care. And then I agree with you about the chronic disease. So obesity, diabetes, heart disease, hypertension, those are all really important spots, which you can definitely make an impact. So I think that's a great point. So Christina, I think that we're going to have to talk about this again. Like, I don't think and maybe we need to move it up in the agenda so that we have a little bit more time. And I also wonder, again, are there places where we can create sort of a draft of what we think is the way to spend our time in these three areas where we could partner and or make an impact and socialize that with other groups of individuals to say, does this resonate? What do you think? And I think partnering with the health systems and the schools is a way, because I know that at our health system, we are focused on all three of those things, probably more focused on behavioral health, mental health, and chronic disease. Environmental health is important too. But yeah, I think we should probably talk more about this because we didn't give it ample time. So Christy, I apologize. You're at the end. It's a good thing we have so many things to talk about. It's a bad thing that if you're at the end, your time gets cut short. So I apologize, but I think we're going to bring you back and put you at the top of the agenda right after Christina. So other comments in our last few minutes? Okay. Oh, so that's great. Thank you, Teresa, for putting, so members of the community who attended, you can submit your comments. That'd be great. So, okay. Christina, anything else that we should try to cover in the last 60 seconds?
No, I don't think so. I think that this really has been a packed agenda. There really is so much for us to talk about, not only at the federal level, but also at the local level. This work is ongoing, it is critical, it's important. And I think the work that we're doing across the entire Office of Public Health is not only, directed towards, supporting the health and wellness of our entire county, but also building, strong and trusting relationships with our residents. So, I'm so delighted and grateful for all of you to be here today, the time that you take to be a part of this work and your guidance and your support. Thank you very much. And I hope you all have a great week ahead.
Yeah. So I'll thank as well the entire team. You all did a great job presenting. Thank you to the community members for joining us, and thank you to our board members. Our next meeting is December 3rd. It is in person, to be very exciting. And if I could have a motion for adjournment, that'd be great.
Motion.
Thank you. Second. Thanks, Marty. All right. Thank you, everybody. Be well, and we'll see you in December.
Thank you.
Thank you.
Yeah.
Go Birds.